Hello, I'm René Monberdi, and we are working today on system complexity, risk management in relation to patient safety. Of course, there are simple systems. Some are complicated, and some are complex. And you see on this scene clearly that the system is not simple nor complicated, but complex because everybody is aiming at different objectives which are contradictory one another. The challenge of complexity in healthcare is not new. This is a very old paper dated 2001 that makes really a good vision of what means the complexity in healthcare. Newton's clockwork universe, in which big problems can be broken down into smaller ones, analyzed and solved by rational deduction, has strongly influenced the way we are thinking problems. But the machine metaphor let us down badly when no part of the equation is content, independent, or predictable, and that is clearly what the healthcare system is. The healthcare system is a complex system, and a complex system is first a complex adaptive system, a collection of individual agents with freedom to act in ways that are not always totally predictable, and whose actions are interconnected so that one agent actions change the context for other agents. Of course, we have many, many examples of that. And if we just widen a little bit this vision of complexity, we can think about the regulations. We have billions of regulations moving continuously in the medical system, and we enforced the regulation with survey, certification, penalties. However, again and again, in contrast to mechanical system in which component parts interact linearly, which is clearly the way the machines are doing, the system that we address today are totally non-linear. And as more regulation are created to control the behavior of such complex system, like, in a way, the medical system, the more the system may deviate from the desired outcome. And here you have a very recent contribution of the Australian Institute, and you see that if we try to apply that general vision complexity in healthcare to patient safety, which is precisely the topic of today, we can see that the origin of errors are interpreted in many different ways. And since we can interpret why errors occur in different ways, we enter into the complexity of really framing the causes and then for addressing human errors. Because we cannot, the standard way of fighting errors is to understand the causes and then to suppress the causes. But if we have a different interpretation of what is the cause, of course we cannot really suppress easily the errors. So if I want to summarize this introductory vision on complexity, I can refer to the inductivist Turkey of Bertrand Russell. It's a nice Turkey who wants really the best for the other turkeys. So this turkey is looking at the quantity of grains that may fit at best the health of the rest of the turkeys. And after a scientific evaluation, it is absolutely clear that about 200 grains is giving the best health for the turkeys. So it's just a mathematical vision, analytical vision. It's a linear vision of what is the best. And of course, you're increasing trust and confidence the more you are clearly envisioning what is the best solution for the turkey. And then come Christmas. And you see what is a nonlinear system. You spend all your energy in calculating the best with a linear system, and at the end, the turkeys that are the more healthy are the ones that will be killed for Christmas to be eaten. And of course, this is the kind of logics that explain that just thinking in linear terms is wrong in a complex system. And we can try now to focus a little bit more on the history of patient safety and how it has become more and more complex. We started with simple ideas. We started with research into medical accidents, just looking at causes. And we had the vision at that time that if we were able to fix the causes, the problem will disappear. Very quickly, we realized that it was not enough. So we learned from other industries. We have, of course, the work of Jim Reason. And we learned that there are many strategies that are used in other industries that are different from the one we were using at that time in healthcare. We introduced the logics of accident analysis. We introduce many logics that are connected to complex systems. And we develop incident reporting, incident analysis. We said much more about complaints and litigation. And in a way, we develop risk management standards. And of course, one of the consequences for that was to develop barriers for which we know that any of these barriers is not enough to preserve safety, but the accumulation of barriers may be very effective. This is the Reason model. And we were thinking that we should be in control with these new ideas coming in the field of patient safety. That was not enough, again, because the system was progressively complexifying. So we needed to add other dimensions, qualitative dimensions, safety cultures, and we imported checklists, bundles, and we also tackled safety across organizations. And we had successes, major successes, but just in focal clinical areas. We improved mortality in some way, post-op infection, major complication rate, central line infection decreased. We had many other local successes. But at global, if we look at the results for the nation or for the hospital, even the hospital, we are not really in control of risk because there's separation between local successes and the global victory. And one of the reasons behind it is the complexity. The system is rapidly changing, and we don't just need a local vision, we need a global vision with problems that interact to make the system so complex. And escalating all problems with even more complex new problems is the rule. And there is a paradox behind that. The system is becoming complex because of our excellence. The more we are developing new knowledge, the more we are complexifying the system, increasing the burden and the complexity of care, and the more we have problems with patient safety. And one of the good examples of that is clearly that safety in healthcare is a moving target. We had for long maybe 2 fingers as determinant for patient safety, and now we are progressively heading fingers. Now we have 5, maybe tomorrow 6. And what are these fingers? For example, the first finger is poor access. Poor access is a new finger. For long, it was just a matter of money to access the healthcare system. But now it's not just a problem of money. It's a problem of finding the right doctor at the right place at the right moment. And this is really a complex problem. If you just mind about stroke, the new stroke strategy for curing stroke asks for having within 4 hours after the stroke a high RAM and then an access to a neuroradiologist, which is just incredibly complex at the level of the territory. It's very good in the very central hospital of London during week. I'm not sure even in this hospital it's so sure is so certain on weekends. But if you think about the global territory, of course it's very difficult, of course. The second and third fingers are very classic and whole fingers, adverse event associated with poor care. We are not following the recommendation. But even that, we are so many recommendations popping up in a system that it's more and more difficult to follow recommendation, and also adverse event associated with the care environment. And we can think about falls, about nosocomial infections, and this is a very classic finger. But now we have new fingers again, the poor share information and partnership with patients, which is really a new challenge. It was existing, but not at the size it is today. So we have really to increase this concern for being in control of safety. And the last is just incredible errors. We can have people dying into lift because the lift is jammed, and this is not something that we think about before, but it's something occurring in complex system. Also, the system is very fragmented. So we are missing a lot of opportunities when we are coordinating carriers among themselves. And of course, if you want to capture progressively the complexity of the present, one thing which really makes the healthcare system different from other systems is the half-life of knowledge. You have many papers telling us that the half-life of knowledge in healthcare is now below 5 years and a half, which means that if you consider the best review published in the best journal on a medical area, within 5 years and decimal 5 years and a half of the review, half of the knowledge in this journal will be considered in trouble with the new innovations. And of course, this is terrible because it means that the healthcare system is very unstable and very unstable compared to the nuclear industry, 70 years for the half-life, or even for the aviation industry, 30 years for the half-life. And this is in proportion also the number of publication of papers is exploding. And we have to face this instability of the system as a complex dimension that really increase the difficulty for all professionals. Another problem is that the patients are changing again and again thanks to our excellence. We are creating patients by making patients surviving to acute disease that should have killed them within 3 months or 3 years only 10 years ago. So we have increasing population, baby boomers, generation of peacetime, improving living condition, more access to care, reduced infant mortality, and biomedical science that are changing the picture for the future. And here you see the percentage of population over 60 now in 2030 and in 2050. And you see that this percentage may reach over 40% of the population in some countries, and will be extremely high in all countries in the world because of massive aging, and again because of the excellence of healthcare. And this is changing totally the system and increasing the complexity because we have more patients, much more patients, and we have to deal with more fragile, frail patients. And of course, this is increasing the way of, this is weighing on the organization and on the way we are delivering care. And this is not just for the rich countries. As you may see here, the Alzheimer's disease will grow more in low and middle income countries than in high income countries. So it's not just a matter of being rich or poor, it's a global, worldwide complexity coming very quickly in the healthcare system. And here are examples from Japan. You see the number of dementia patients in million growing very quickly. You see also that the long-term care expenses are exploding with the patient massively aging. And of course, this is adding dimensions in the systems that are not purely technical or not purely medical, but the global picture has to consider also this problem, because if you have no money, you cannot really deliver the care. And if you are in control for your money, you're delivering progressively a different care. So you cannot think just technically on the care, but you have to have a global vision, a global picture of the healthcare system, and understand how the global picture interacts with patient safety at the very local level. And of course, if you look at the system and try to understand the system at present, patient safety, you can easily think that we have at the top, as just I mentioned before, a quality ambition with really no limit. We have a speed of knowledge, increasing knowledge, which is really incredible. I just mentioned 5.5 years for half-life of knowledge. And of course, we have the ambition of including more patients continuously, more complex, frail patients. And that's really the ambition of healthcare. But not the opposite. If you accept the idea that if you do more continuously, you increase your recommendation, you change your protocols, you increase the complexity, then you're provoking probably a kind of consequence in terms of additional risk, and that is a threat to health. So it's a continuum between the push towards a better ambition in quality and accompanying risk at the bottom level of patient safety. And one of the problems we have is that probably the way we are mining the ambition for the future of the system, the new treatment, the new solution for healthcare, is different from the way we have to mine the intervention to reduce harm, which is clearly the area of safety. And of course, as I just mentioned before, there's a relation between the speed of ambition and the risk for patient safety. And the more we increase hope, which is the very core of healthcare, the more we include patients for surgery over 85, 95, why not 100? The more we are introducing new protocols, very demanding new protocols, the more the system as it is today is unprepared and taking risk and increasing errors. So we have to make the balance between the two, and that is part of the logic of complexity. You have not a simple solution. You cannot say just, well, I have to suppress any risk, because this is not making any sense for healthcare. Healthcare is an area where taking risk is for the benefits of patients. It's the ambition of healthcare to take more risk for better results at the population level. So we take risk, and we have to control the risk we have accepted. And this is really leading to mind the future and to address complex patient safety models. So what has already changed in that vision is to have less reliance on acute care and spend more time on primary care because of the fragmented system and the rapid discharge from acute care. The role of primary care is growing progressively. We, of course, have sophisticated treatment emerging more and more, diagnosis, testing protocols, less invasive treatments. We have shorter stay in hospital, rapid discharge, and in many cases, day surgery, day medicine, no hospital admission at all. What needs to change? We need to fund a wider variety of health service, we need to reconsider organization. We cannot think just patient safety in terms of technical act on the patient. It's the background of that is very central. The organization in which professionals are developing their knowledge and coordinating between themselves is very strategic. This requires really a conceptual shift and need a new system-wide perspective, which is really the core vision of complex system. And the change require are even more fundamental because the very purpose of healthcare must change from health and restoration to supporting well-being in the face of chronic disease and frailty. So we need to rethink patient safety in this logic of complex system. And we have probably 5 big changes to consider. We have to change definition because patient safety is becoming the management of risk over time and not the suppression of risk. We have to understand risk and harm through the patient eyes, to consider the balance of benefits and harm within an episode of care instead of just an act, to adopt different safety models dependent on context, and use a wider range of safety strategies and interventions. Look at the change of definition. Just a comment about this example. This is a result of the French hospital accreditation at the first visit of accreditation. As you may see, there are almost, not really 50%, but 40% of the French hospital had severe problems with accreditation on borrowed time for 10%, and accreditation with reservation for 36%. There's a blue and blue section on the left. If we come back, or at the end of this visit, the standard logic is to negotiate in a way with the accreditation agency some delay to comply with procedures and come back to compliance. But when we come back 6 months, 12 months, 18 months after for the second visit to the same hospital, very little has changed. We still have 7% of the hospital with accreditation and borrowed time. We still have 28% of the hospital with reservation. What means this result? It just means that in complex system, there are so many constraints on the system, including staffing, including the seniority of the staff, including the money, including the technical devices and the organization, that even the hospital is willing to comply with the new regulation, it makes the compliance very difficult, even within a period of 20 months. And if you cannot comply, now the logic for patient safety is to control. Okay, you cannot comply with the ideal, but you can be in control of risk management. And that's the job. The job is not necessarily to be compliant with everything because the recommendations are changing so quickly, the system is so complex that almost half of the hospital continuously do not comply. But if you accept that, instead of saying, well, it's not acceptable, because it's just a reality gap. If you accept that, then there's another solution, which is in connection to the complexity solution, to control the risk despite you are not really complying with all standards. And the goal becomes to control the system at an acceptable level. And of course, to decide for no-go anytime you are below this acceptable level. So you have 2 tasks important in complex system. One is to accept that One is to accept that you will not be continuously complying with all standards. This is a vision of the ideal and linear system. Second is that you will have to control the system within acceptable bars, and you need some knowledge for that. So you need to educate people for doing that. And the last point is that, of course, you have to detect when you are below the acceptable bar, and at that stage, the solution is very simple: no go. So this is a new vision for complex system and controlling complex system. And in a way, we used for years and years the solution A, which is a retrospective solution for patient safety, which just says safety is no harm. The aim of healthcare is healing. We want zero accident, zero incident, zero error applied to all individual acts. And the definition of best safety is forever. No risk, no error, no accident. And this is the way we have minded safety for years. But progressively, and this is true for all complex systems, we have to jump on a proactive B vision. Safety is risk management. The aim of healthcare is living longer and healthier. And the safety priority is moved from reducing all preventable complications and harm to making all complication and harm totally reversible and without prejudice to the patient, which means you're putting all your effort on detection and recovery. You don't bet on the idea that you will suppress all errors or incidents, but you really organize a system as a dynamic system, as a complex system, to be in control and detect and recover very quickly. Of course, you have also to consider risk and harm through the patient eyes. You cannot continue in a complex system just to trust your own vision of professional, because in a way, the patient, and it is specifically true in a very fragmented system, as it is progressively because of rapid discharge from one carer to another, the more you're going that direction, the more the unique person who knows about the story is a patient. So if you don't ask the patient to become a partner, you will be unable to detect patient safety problems. So it's quite important. And it's true that by the time harm is conceived very broadly, encompassing both serious disruption of treatment and distressing events in the mind of the patient, which is different from the mind of professionals, where in general we only see technical problems into the story of harms. Harms include serious failures to provide appropriate treatment, as well as harm that occurs over and above the treatment provided. And harm is seen not in terms of incident, but as trajectory within a person's life, which is really changing the spectrum on, by which you are looking at the problem of patient safety. And of course, you see patients here. One is suffering from arthritis with the 5 level that we have seen before on a y-axis, and you see that for arthritis, the care were quite good at this period of time. You see another patient with a hip fracture, and you see that here, this patient had a problem and recovered from the problem. But you see the line going down to the risk area, if you remember correctly what I shown a few minutes ago. The same applied to the third patient who was suffering from diabetes. And you see that he had a problem at the moment. And the same again applied to a fourth patient who was suffering from depression. But the very story is that this is the same patient. Because with the silo approach, looking disease by disease, you're considering a patient as a decomposition of singular approaches, medical approaches. But life is different. Life is just accumulation of problems. Life is arthritis with diabetes, with hip fractures and depression. And then the interaction between all these diseases, that is the story of this patient, makes the complexity of the approach obvious. So we probably also need, for many other aspects in patient safety that are patient-related and not included into the professional vision, but part of the complexity. And for example, many patients live alone today, and they are so far or so so in trouble to access the system that when they have 2 or 3 diseases and when they live 20 kilometers or 30 kilometers far from a big town, they have rendezvous on Monday for lab examination, on Tuesday for the radio examination, X-ray examination, on Wednesday with a first physician, and on Thursday with another physician. Can you imagine the life of this patient? Can you imagine that in a system that provides rendezvous in such a way that is totally uncoordinated, it is good for patient safety? Of course, no. So we are not really focusing here on technical act. We are focusing on the complexity of the system, on parallel physicians, nurses that are not coordinating one another. And of course, this is one of the big steps we have to control in the future and try to organize. Also, it's quite important to understand that the hospital, but it's true also with the primary care, is not one industry, as aviation is one industry, as oil industry, if refinery is one industry. Oil industry is many, but a refinery is one industry. Nuclear industry is one industry. Healthcare is not one industry, it's many industry. Because when you compare the ICU context in the hospital or the emergency unit with the radiotherapy or the blood transfusion, you are totally in different space in terms of reference for safety models. Some of the hospital, some section, radiotherapy, blood transfusion, lab testing, are probably really similar to all this industry that is avoiding risk and which is termed ultra safe. It's the case of aviation. When you want to go to Boston and there's a snow tempest in Boston, you're grounded in London for 1 day, 2 days, 3 days. And the solution is to avoid the exposition to risk. So this is based on a supervisory system. So you have a lot of very strong agencies and recommendations, air traffic control for obviously the aviation, but if you turn to radiotherapy, you have agencies looking at the risk with radiotherapy and very, very requiring obedience and to really observe and comply with all the recommendation. The priority is given to prevention. Of course, as I said, a strong regulatory control, and training is focused on rigorous procedures and management of workload. But this is just a small part of the hospital. Probably 60% of the hospital is referring to another model, which is much more the high reliability model, the HRO. Risk is not soft in this model, it's not soft out, but is inherent in the profession. It's typical of the operating theater. Everything is scheduled. So you are, for scheduled surgery, everything is scheduled. So you know a week before what will occur next Thursday. Everything is ready, you know what type of patients for what type of surgery. But the reality is that because of the complexity of the system, you will never do what you have planned. You will systematically have to adapt. And you are betting your adaptation group intelligence. There's no supervisory control. There's a local control at the level of the group, at the level of the ward or the operating theater, maximum at the level of the hospital, but then there's no really supervisory control at the nation level in healthcare, nowhere. And there are mutual protection of team members. Training and safety focus on adaptability and flexibility of procedures. So in this model, you understand clearly that the problem is to organize the group and to train the group. So it's clearly the model where you have to develop a lot of team training. But you have also some section of the hospital that are clearly like the fishermen. Taking risk is the essence of the profession, emergency medicine. everything that is non-scheduled in the hospital, where you have to face unpredictable type of patients in unpredictable context. And there's also, because it's a complex system, the rationale of healthcare to consider that it is more important to give access to the patient than to guarantee that the access is totally safe. So if a patient is coming, the logic of telling the patient, I cannot deliver any care to you because my conditions of work, my working conditions are not enough control at that time, is something that almost doesn't exist in the healthcare system. So you upset the patient, and then you do, in very degraded condition, the care. And of course, this is, in a way, the essence of the fishing industry, and all these industries that are at high risk. Working conditions are unstable and sometimes unforeseeable. And what is important in that case is to have the right and best professional. So there's a cult of champions, of heroes, that is important in that section. Success analysis is more important than accident analysis, and training is the acquisition of expertise, understanding our limitations. And you see, at the end, you have the risk going from very unsafe conditions, 10 to minus 1, every 10 trial, every 10 patients you kill one, to something which is ultra safe, where imagine every million patients you kill one. And on this extremely large section of risk, you can project all the industries. And you see that some are ultra adaptive, not very safe. But again, this is probably the case of the ICU, the trauma centers. And the problem is not that much to be ultra safe. The problem is first to deliver care. And once you have delivered care, the second priority is to become safe. But the second priority is not the first priority. Because if you put safety first, totally first, you will not upset patients in many conditions, in such conditions. So it is because taking risk is the essence of the profession, that you have a model behind. On the opposite, you have ultra-safe systems. In that case, no-go is the main answer. If you have any problem, you stop. And the regulators tell you no-go. It is the case in aviation, but it's the case in radiotherapy and many other sections where you have only the best and most performant industries in terms of safety. And in the middle, you have the HRO model. Risk is not sought out, but it is inherent in the profession. And you understand that hospitals, primary care, home care are land of these many industries, depending on how you can organize, stabilize, and predict what will occur. You have to address one of these models. And the conditions for developing safety is different from one model to another. Finally, it's quite important also to consider that adverse event analysis has been long considered as a problem of a simple problem. You have an adverse event, and you look at the immediate causes, a little bit at in-depth causes. But when you look at in-depth causes in the present model, for most you look at in-depth causes that date back 2 days, 3 days, or 5 days. And you have very little look at what will be the consequence of the adverse event, because you are just you're just looking at the past and retrospective. And the future, if you want to really to address the complexity and take lessons from accident analysis, is to look at the causes, yes, of course, but not just for the 2 days before, but on a long pattern of time where the patients started the episode of the disease, the patient journey. And then you have also to consider the consequence of adverse events. How far the team has been able to detect problems, how far it has been able to recover problems, and eventually to mitigate problems. And the total is really showing a different vision on accident analysis, because you move from understanding the problem at the level of the act to understanding the problem and the control of the problem at the level of the patient journey. And it is very true also that the new conditions of care, home care for example, are moving a lot and increasing the level of complexity and the type of problems we have to face. On average of 30% of home care patients experience an adverse event. Older patients and those with more comorbidities and medication are at greater risk. And of course, well, we have really to develop new ideas for these patients. So if we try to summarize what we want to change for a complex system in terms of accident analysis, we need to go from the simple identification and decision to investigate to something where you need the patients also for identification of problems, because they are the only persons who knows about the total story. We need to select people for investigation team. That's what we are doing today, but tomorrow we will have probably to include patient and family. We have organization and data gathering today, but again, probably tomorrow it will be very useful to ask patients to tell the story in parallel of the organization and technical organization. We have to identify care delivery problems. That's what we are doing today. But tomorrow, what is important is to add a concern about detection and recovery, the consequence of the problem. We identify contributory factors, and again, we have to add detection and recovery. We support for patients, families, and staff very little today. Probably we have to do much more tomorrow. Recommend and develop an action plan, but probably is much more than an action plan, and much more than just telling at the end of the accident analysis procedure, we should comply, because in this case, we have not complied with the regulation. As I said before, in maybe 50% of the case, you will not be able to comply. So it's not the answer to just say, as a gospel, I will comply, because if you are unable to comply, the best is to say, I will not comply maybe, or I will try my best to comply, of course, but if I cannot comply, I will develop another strategy to make the care as safe as possible. And this is really what we developed with Charles Vincent in our recent book on considering the 5 families of strategies. You see, on the optimization strategy side, we have the top, adopt best practices. That is the idea of complying with the best strategies. Of course, as I said before, it is the ideal, but in 50, 40, 30%, depending on where you are, in the context you're working, you will be unable to comply. So you will have to use the 4 other families. Optimize working conditions whenever possible. Increase risk control. And you can restrain the range of activity to that can be properly policed. And this is really easy to do if you have not the right doctor who is making surgery at a certain level of complexity because he is or she is in vacation during August. Please stop recruiting patients that are complex patients, because only this doctor can do the good job. So this is really increasing risk control. We can, of course, adapt and recover, abstract intelligent adaptation to context. We can develop a lot of knowledge on our managers to do a better job in terms of teamwork and in terms of recovering and detecting errors at the team level. And we can mitigate, and this is also something we have to learn. Foresee and mitigate consequences of flows, report incident and accident, but say thank you to acknowledge team effort and say sorry to clients and patients anytime it is useful. And of course, we overused, as I said before, the best practice strategies, and we underused all the others. So it's quite important in a complex system to increase the range of strategies that we can use for intervention. So if we jump to the conclusion, there's a lot of change coming, very important in the future, and again, we have to change because the system is much more complex, and the system is much more complex, need to be seen at a global level and not just at the technical level of the medical professional because of the excellence of medicine. Is it just because we are considering incredibly demanding treatment and protocols for incredibly frail patients, and this is the job, that the system cannot continue to be considered as it was two decades ago. And we need to consider now not only the technical act, but the organization, the fragmentation, the patient journey. And as you see, we have to move from one size fits all to personalized medicine. We have to move from fragmented one way to patient into the flow and integrated two ways. We have to move from provider-centric to patient-centric. We have to move from centralized hospital with a logic of stay to rapid discharge and decentralized shift to community, which means that maybe, and this is one step more for adding complexity, in the near future, the community will be considered as a carer, not just as a community, but as a needed carer for developing care for home care. And we're going from a logic of stay to a logic of flow, from invasive to less invasive, image-based treatment, from reimbursement procedure-based to episode-based, outcome-based, and for treating sickness to preventing sickness. And if I try to conclude on a last point on complexity, look at the global problem of safety. Safety total is the sum of two components. Safety imposed, all the rules, all the constraints, all what you can mine in terms of imposing things on the system, and of course it's important. And a second component, which is safety managed by people, the intelligence of worker, the resilience in a way, the only part of the system which is really adaptive. If you look at craftsman industry, and in a way the healthcare system for 80% is a craftsman industry, you never make a turn, you don't make any difference between two pilots of British Airways. One is coming, flying, replaced by another. All pilots are equivalent for you. But you have chosen your surgeon because you think that surgeon A is much better than surgeon B. Of course, it's just, maybe it's not true, but it's your opinion. And this is typical of a craftsman industry. You're selling your difference. If you're selling your difference, you are in a craftsman industry. If you say, I'm not the same than the other, I'm not with exactly the same profile, I'm different, you are in a craftsman industry. In a craftsman industry, the safety total is not that much, is not that good, because you are not betting on rules. Safety imposed by rule is very limited. You are betting on the intelligence of workers, on safety managed, on their knowledge. And the result is not that exceptional for safety total. If I come as a safety specialist, I will increase safety imposed by rule, SI. And I will be successful. Safety total will be much better. But you have to consider that safety manage the expertise of your professional will decrease. And the reason is that the expertise is a result of the variety of exposition to different problems. If you reduce the work to a standardized work within a box by rules, safety imposed, you're progressively reducing also the opportunity to develop the expertise on the safety managed section. And of course, that will be a problem because in a system where you need adaptation because the system is very unstable like the healthcare system, you cannot totally bet on ruling the system. You cannot totally bet on making anything enclosed into a box as the aviation is doing. You will have to be adaptive. And if you have to be adaptive, you will need to have a certain amount of expertise, which is beyond the expertise resulting from a system which is totally capsulated into a box. And there's no solution for increasing the total safety by increasing both the rule in the system and the expertise of operator. So that's one of the last idea that really we have to address in the future to control the growing complexity of the system. And you see we have three systems. We have seen that very quickly, but you have on one axis the adaptation and the other axis the safety. And if you bet on individual competences and expertise, you will be very adaptive, but not that safe. If you bet on ultra-safe system, you will bet on supervision, on everything under control of procedures. You will be extremely safe, but you will be unable to adapt to maybe 15% of the patients. So that's exactly the challenge of complexity in healthcare in patient safety. And I hope the future will give us more solution, because at that time, we have to arbitrate between these different solutions, and no one is perfect. That's very typical of complex system. Thank you.